Well, welcome everyone. This is Jen Hurley. I am the slide operator for today's presentation. I just wanted to welcome you all to the Community Focused Reducing Readmissions webinar presentation as part of the Clinical Discussions 2013 webinar series brought to you by the Physician Leadership Network. I just have a few items of housekeeping before we agenda, welcome and housekeeping, an introduction, success stories, gaps, barriers, question and answer, and then the adjournment. Housekeeping, if you wouldn't mind, as you're joining in on the call, please mute your line using any mute button on your phone directly. I do have the calls on a mute all function right now, but just to be safe, it's helpful to mute your line directly, and we are hoping that you will not place the call on hold because that will share your on-hold music with the call, so please do not place us on hold. And then we are going to have a question-and-answer session following the last presentation, and we encourage you to submit your questions using the chat feature, but we will enable audio controls during that time. So please, if you have further questions, please feel free to use the chat function, and we'll look forward to hearing from all of you a little later in the presentation. So today's learning objectives, we're going to describe successful community-based solutions, improving care conditions, reducing readmits. We're going to identify ongoing barriers to improving transitions of care. We're going to consider, reveal opportunities to overcome barriers. So without further ado, I'd like to introduce our host for today's webinar, Dr. Mims, Medical Director, Medicare Quality Improvement of Alliant GMCF. Dr. Mims.
Thank you, Jen. I'd like to say a warm welcome to everybody on the phone and those of you who have also been able to join us on the webinar. We're very excited to kick off this initial session of the Physician Leadership Network series of clinical discussions. This whole idea of the clinical discussion series came out of a group of physicians who honestly felt that we could collaborate more in overcoming some of the challenges and learning best practices from one another on topics that we're currently dealing with, and that those that will go probably into the next scope of work. We know that those of you on the ground are the ones who are actively working with the providers and working with Medicare beneficiaries, and you're learning a lot, and a lot of that needs to be shared, and it may or may never be part of a peer-reviewed journal. But because you're learning all this information now, we thought it would be most valuable to be able to share it on this type of a webinar. A polling question is going to come up on your right-hand screen, and it's going to first ask who is on the line. As we're going to be doing this series of webinars over the next several weeks, we'll do this poll each time. And although the question talks about which discipline that you come from, and whether or not you work on the care transitions theme, what we're hoping to accomplish is to get a broad array of people on each one of the calls, because we think that a lot of our work goes across AIM. So today we're going to be talking about community-based reducing readmissions, but we know that nursing homes are part of this. We know that medication safety is a part of it. We know that beneficiary engagement is all an equal part to this. So can I have the polling question come up, Ashley, as we're going through this? I do want to put in one caveat that what this discussion is not. This discussion is not a discussion of contract modifications, problems with deliverables, or anything like that. It's important to discuss those type of issues with your core, your NCC, and others, but that is not part of this whole series. So I would ask you to refrain from that type of discussion today and as our series goes on. I don't see our poll coming up here, so we will get to that when it does come. But at this point in time, I'd like to turn the conversation over to our facilitator for today, which is Andy Miller. So Dr. Andrew Miller is a medical director the New Jersey QIO, and he's been a leader in care transitions for a long time. He's recently been promoted to take more of a lead with the Care Transitions Initiative as part of the NCC. So Dr. Andy Miller, I turn it over to you.
Thank you, Adrienne. Good morning and or afternoon to everybody. We're coming to you live from phones all over the country for this webinar, and we thank you all for joining us today. The beeps that you're hearing in the background are people joining the call, so that the good news is there are still people joining in this discussion. The bad news is we'll be interrupted occasionally, but hopefully we've got a good group and we'll have a good discussion. As you can see from the learning objectives that Jen mentioned and showed, and you'll see in the agenda on the next slide, I believe, for today's webinar, we're planning to provide you with some example stories from QIOs related to the Integrating Care for Populations and Communities aim of the 10th scope of work. Next, we'll have two presentations after that focus on identified barriers or gaps on improving care transitions. And then we'll have a discussion about these barriers, as well as other issues that are involved in the work of QIO's transitions of care. The QIOs across the country have done a lot of impressive work related to improving care transitions and preventing avoidable hospital readmissions as part of the 10th scope of work. Almost every one of the QIOs could probably have provided us with a valuable success story around this aim. Having said that, however, the work that you're going to hear about from the first four presenters really does stand out. The 5 minutes that we've given to each of them is not enough to do justice to their efforts, but we hope that you'll be encouraged or even inspired by their presentations, and you can contact them. Their contact information will be shown during the webinar if you want additional information. Or we encourage you to chat questions. We hope that we'll have time to address them during the webinar and during the discussion after the presentations. And we know people have signed on to hear the presentation, so we will get to that right now. Our first speaker is Barb Averett from Health Services Advisory Group, the Arizona QIO, who's going to discuss HSAG's statewide readmission reduction campaign. Barb?
Good morning, and thank you for the opportunity to share Arizona's statewide care transitions campaign called No Place Like Home. According to data disseminated by the NCC recently, Arizona has achieved a relative improvement rate of 12% for readmissions. That's the third highest in the country. We're quite proud of that, and we attribute it to the way we organize the activities in the campaign, which I'll share with you in the next 5 minutes. But before I do that, I just want to review with you a little bit about Arizona. Arizona currently has 6.5 million people living in the state. This is according to the U.S. Census Bureau. There are 15 counties in Arizona, but 60% of the population lives in one county, Maricopa, and that's where Phoenix, Arizona is. It's the fourth largest city by population. 35 of Arizona's 77 hospitals are located in Maricopa County. Maricopa County is the fourth largest county by population in the United States. And the state of Arizona is also, though, geographically large compared to other states in the United States. And in fact, when considering land and water mass, 6 of Arizona's counties are in the top 20. So we have quite a few challenges in that. The complexions of the counties are also very diverse. Maricopa County is a metropolitan urban area, while about 1/4 of the state is federal land that serves as the home to 16 Native American tribes and people. Those are located mostly in the northern Arizona region and in the southern Arizona region. So the regions also have areas that are rural and frontier in nature, and then southern Arizona region, being closely located to the border, has its own unique challenges. And so it was for this reason that we decided to section off Arizona into 6 regions. Next slide. Realizing the limitations on time and other resources, a strategy was developed to focus on those organizations that had the highest readmission rate in the state and the highest volume. To accomplish this, we developed a report using the ASAT data from the NCC, and we ranked every hospital by readmission rate and volume for all-cause cases. We then reviewed that data and made a targeted list of those that we would do a site visit with. During the time of this report, we had 78 hospitals, and we targeted on 40 of them in Arizona. We had those 40 join the campaign, and those 40 account for 3 out of 4 of Arizona's readmissions. By working with these hospitals, we believe a large opportunity existed whereby the post-acute providers would subsequently join the campaign in an effort to support the collaboration with their local hospitals. This would serve as a cornerstone and foundation for the community building and impacting the whole state. Next slide. I'm not going to go through every piece of text on here. This is for your reference for later, but just so that you can see, we utilize a variety of methods to move the statewide rate upon every medium, and in a moment I'll expand on that. This slide shows the various activities and ongoing internal quality activities conducted to help us be nimble and relevant based on feedback from our provider participants and internal observations. In December last year, we conducted an internal SWOT analysis for care transitions and a needs assessment from the participants. From that, we made program changes in 2013. But all of this started, I believe, as the catalyst of success was having an initial face-to-face visit with hospital CEOs and CMOs. And during those visits, I took my CMO, Dr. Howard Pitlock, with me. And I have to say, having him with me was significant. It communicated the high priority that this was to the C-suite and allowed for peer-to-peer sharing. Next slide. And what this shows are the different various activities that we've had for engagement. One-to-one site visits with hospitals that included meeting with CEOs and CMOs was significant. We have had 2 statewide lands, and a third one is slated to occur, and that's where all of us participants from the state convene. Then we have quarterly land meetings for each of the 6 geographic regions, and that brings providers together across the continuum to talk about their local issues and share strategies being used that they can shamelessly steal. We've conducted monthly webinars about various care transition topics. We have a 30-minute monthly information WebEx to chat about new resources and upcoming offerings. We've issued 5 quarterly hospital readmission data reports to every hospital in the state, regardless of whether they've worked with us in the campaign or not, and weekly emails that go to about 800 individual participants. And as you can see on this chart, it kind of tells you what the tone is for those weekly emails. And, of course, we have a dedicated website for care transitions that is www.noplacelikehomeaz.com. And that concludes my presentation. Thank you very much.
Thank you, Barb. Our next speaker, we're just going to keep moving here, is Karen Southard from the Carolina Center for Medical Excellence, which is the QIO for North and South Carolina, who will talk about how they were able to engage and recruit so many communities in North Carolina for the ICPC AIM. Karen? Hello, Karen?
Karen, if you could press *6* to unmute your line.
Hello? Hi, this is Karen. Can you hear me?
Yes, we can, Karen.
Okay,
go right ahead.
Great. So sorry. So thank you very much for allowing me this opportunity. When I was preparing this, I thought about, well, what should we title it? And I thought Igniting the Fire positions ourselves with our story with North Carolina. Next slide. So out of the gate, for our proposal for our contract, we discussed probably being able to handle about 2 communities, and that was in the beginning, but actually wind up today have engaged 25. And I guess it's much more on a circumstantial that we received all these calls flooded into our office immediately at the beginning of the contract. On August the 3rd, we actually had our first community who was interested in going forward, very mobilized, engaged community for CCTP. So from there, we worked with them, and we learned a lot in the beginning because a lot of our material wasn't even ready for us. So we quickly became good partners with our NCC who helped us get out of the gate. And through, just having some conversation with them and seeing the information that the state was in need for the care transition in the CCTP, we mobilized and started to have conversations with our partners. And then through that, we had opportunities to share education and present across the state. And as you can see here, a snapshot in North Carolina, we have 100 counties in North Carolina, and today we have 50 of the counties that are engaged with the QIO in some capacity. We have 3 communities that have been awarded the CCTP. We also have had 13 formal, and then the rest are engaged. So we're very happy that we've had so much momentum around this in the state. Next slide, please. So out of that total 25 engagements, currently have roughly 17 that are formally and actively participating in recruiting in care transition. You can see here the reach, our beneficiary reach for our state is 61% of our beneficiaries are in our care transition community. So we're very excited and very happy about that, that we have such a large reach. And we have a very good potential impact on 241,295 Medicare discharges coming out well. And then I just wanted to share with you out of our C3 a snapshot of the breakdown of participants. We have engaged quite a bit with physicians, home health agencies, our long-term care, palliative care, and area on aging. So we do have some pretty robust partnerships in these communities. Next slide. So, again, in the beginning, when we came out of the gate, I would say it was almost a little chaotic for us because of all the activity, but we decided we would turn to our stakeholders who have always been good partners with us in the past. And so we took on these partners through our journey and still continue to work with them today. And you can see that all of the partners that we've engaged all had the common vision, and that's what we focused on, and that was the partnership for patients. We were all trying to achieve that overall 20% reduction in our state, and many of us had different ways we were approaching it, but we got together, we mobilized, and we had that common vision. Next slide. So that common vision you see here, in the gold, you can see the role in which we, the QIO, took the lead in this and still continues to do this today amongst the partnership. We discussed our roles in partnering. We wanted to make sure we wouldn't duplicate efforts, and much to Barb and the Minnesota QIO, the RARE campaign, we also modeled a statewide campaign, which we have North Carolina Alliance for Effective Care Transitions. Today going on, and that's how we educate and continue to spread the information. But we also became the leader in the community formation, and the partners all looked to us and would work with us when they saw potential community or partnerships that were needing to be formed. We focus very much the same thing on high readmission hospitals and high populations and high readmission areas initially for our strategy. Next slide. The most important thing is we saw that there was plenty of work for all, but we didn't want to duplicate. So as a QIO, we developed community toolkits in which we place those on our website and as our partnership websites as well to promote communities getting started on the work on their own. Those that we did form a collaborative with our North Carolina Quality Center, who was a large hen, and you can see how we divided the work. Took over the hospital root cause, and the QIO did the community formation and the root cause analysis. With that alone, that partnership, we reached over 40 different hospitals, and many of them became our communities. Next slide. And so in the end, today's work, we're really focused on the QIO support and community through learning and action interventions. Through all of the coalition of the 25 communities, we've engaged many of the nursing homes are participating in statewide Interact boot camp, and we'll go for a whole year, and we're covering that actually with our nursing home quality leadership work as well. And also, too, we've engaged with the hospital home and starting a new chapter for CU in 7, because in terms of the partnership, one of the things that we looked at the data and show that we have we really can improve on our early access within that first 7 days post-discharge. And so through involvement of our physicians and on the local chapter of the American College of Cardiologists here, we're going to be doing a See You in 7 campaign, which will focus specifically on improving access for patients within 7 days post-discharge. Next slide. And finally, just to show you, we're also gaining a lot of momentum. This is just on the red side, shows those who are not formed in one of our QIO communities, the relative improvement rate for admissions. This was in 2011, so it's much better now, but was 1.7 versus those who were working with a QIO community was a 2.7 relative improvement. Next slide. And finally, on our readmission, we're very happy with it. Those who are not formally engaged or working with a partnership with the QIO, we're looking at those communities having a 2% relative improvement rate versus the blue, which we've covered. We have a majority of the state covered with our work. Now is showing a 5.5 relative improvement rate in their readmissions. And that's the North Carolina story. Thank you so much for allowing us to share.
Karen, thank you very much for presenting. I just want to point out to everybody, Dr. Mims posted a reminder in the chat box that to please feel free to pose questions. So hopefully you see where that is, and we encourage you to send questions or comments if you have any. Next, we'll hear from Hillary Emtower of the the Colorado Foundation for Medical Care, the Colorado QIO. Will tell us about how they've utilized community organizing principles to build their communities in Colorado. Hillary?
Thanks, Andy. Hi. As if it's a little bit loud, we're actually on the road to lovely Pueblo, Colorado now. And can you guys hear me okay?
Yes, you're fine, Hillary.
So, like Andy mentioned on slide, approach really organizing approach, which we learned through a Harvard online class. And we're trying to organize to be a constituency with a common goal. It's different than initiatives that have been tried in the past. Like we're not training them on lean or awareness. Like I always think of when I worked in the hospital, as a nurse, wash your hands, like raise the awareness to wash your hands. And new technology or services. We're really focusing on those that are already available within the community, such as time, money, staff, relationships, to work towards a common goal. Next slide. So, really simple picture of what the community organizing model looks like and how it works is what is to engage the stakeholders and partners in the community to form a constituency, and then we have them form a leadership kind of based on what we call a snowflake, meaning that it's spread and that not one person is in charge of the initiative because that won't work. And what your common values through shared story, commitment, structure, strategy, really have goals that the community themselves they want to reach. And through that, we with medical and non-medical providers such as the AAA, Healthcare Association, home health agencies, hospitals, non-medical homes, nursing homes, pharmacists, and trying with the physician office. All right, next slide. All right, so really how we spend most of our time is really building intentional relationships. We feel that that's the most important part of any type of organizing we do, because once you have that relationship formed and those values formed, it's harder for people to say no or to say yes, is how we like to look at it. So they develop, there's clear value, purpose around the team, and then also recruit people with different skills and resources. We don't want just the C-suites involved. We want the people on the ground floor, but we also want the people who are at leadership level so we can get that commitment. and really how they can share resources and share what they've learned. And some tools that we found useful is really using a public narrative and having that tell the story itself, because the story really does show what drives people and what's their passion, and can connect them to their community members as well. And then a lot of the structured one-to-one conversations with it, and ask at the end of what you want your community members to do, because if you have a clear ask, then there's some clear expectations set. All right, next slide, please. So here is the map of actors, and with the map of actors, this is something also in the community organizing toolkit. We like to use that because it gives you a visual how to define your community. And what it first use it is that we would look at the social network analysis, or the SNA, that the National Coordinating Center gave to us to see where in a community the transitions were occurring. And so that would give us the kind of a basic figure out who is playing in this game. And then what we do is we take it to the community and ask them to kind of fill in the blanks, like who's missing from this picture, and who's missing from your group, who should be at the table, and who should you schedule a one-on-one to get them involved. And it's just a nice kind of visual reminder. And it has them think about, who is the competition, who's sources, and maybe some opposition. Truly, we don't have that many people, because not too many people want to vocally say they're opposed to improving care transitions. All right, and next, final slide is just an example of another scenario that we've done to get work groups in one of our communities. They do a nightmare dream scenario and talk about what their nightmares of care transitions are, and from that, then pick out what work on, and then they dreamed about what they wanted for ideal care transitions, and match each of these work groups, because they could and have and what then with their headlock measures to measure, and using our data and also an analyst who could help them form customized reports. So using the community or relationships, then using available, I feel like one of the most sustainable that will work even after the QIO walks away from the community. Thank you.
Thank you, Hillary. Hillary, we were only able to hear probably about 3 out of every 4 words you said. I think it was valuable, and I apologize to the group for people who you had to listen hard. I think Hillary's slides did a great job of explaining the work they've done. And Hillary did refer to some tools and techniques from Organizing for Health. A number of us had the opportunity during the 2011 Quality Net meeting to receive training in these techniques. The NCC ran a series of webinars at the beginning of 2012, last year, that were open to everybody, and I believe those webinars and the materials for them are on the ICPC NCC website and are available if you'd like to follow up on these things. For the last, but definitely not the least of our success stories, Sarah Butterfield from iPro, which is the New York QIO, will speak about how iPro was so successful in encouraging communities to apply for CCP funding and to get funded, get approved. Sarah?
Thanks so much, Andy, and thanks to all of you for the opportunity to share success of our CCTC communities. If you go to the next slide, you'll see a map that represents the snapshot of the zip code defined regions where our New York community-based care transitions program awardees are located. So you'll see a very vast distribution as well in the upstate region as well as in our downstate New York City region. There were 12 New York State communities that were awarded funding, which actually represents 50% of the 38 New York State hospitals that were shown on the CMS Community-Based Care Transitions Program high readmission list when CCTP was first launched. So we were successful in getting 42% of them interested in applying and also successfully applying. Those 12 communities represent about 12% of the national CCTP awards. 11 of those communities requested and received technical assistance from our ICTC team, and it was a very hectic time and a very rewarding time to be able to help these communities do a root cause analysis and form a plan for addressing unplanned readmissions. Over 90% or over 90 cross-setting providers were involved in this program, 54 of which were hospitals. The other types of cross-setting providers included home health agencies, hospice organizations, federally qualified health centers, physician practices, and skilled nursing facilities, as well as dialysis centers. So there was a vast representation. There were also multiple hospital communities. So for at least 2 of our applications, there were 10 hospitals that were part of that application. And in addition, there were 10 in one of them, 10 community-based organizations also. So our charge was really getting those folks to partner and get everybody on an equal playing field to be able to participate in this whole process. This whole region of Community-Based Care Transitions Program awardees incorporates 774,554 fee-for-service Medicare beneficiaries. And the primary diagnosis that you saw most of those applications addressing were the heart failure, COPD, pneumonia, diabetes, and end-stage renal disease. And their interventions really crossed over because most of the patients, when you look at the Medicare claims, have multiple versions or comorbidities of those diseases. Next slide, please. I wanted to share with you some of the strategies that supported this success as far as recruitment and outreach to get these communities involved. Initially, we sent an email out to all of the New York State hospitals. We also elicited support from the New York State Provider Associations and also our patient safety organizations within the state to really get the word out about the program and the opportunity to apply and our ability to provide technical assistance. We followed that up with one-on-one telephone contact with all of the 38 New York State high readmission hospitals, as well as some of the other communities where we saw opportunities to apply for the program. We also did regional presentations across the state, and word of mouth really was one of the successful strategies. Once we saw our first community awarded, all of the other communities really took note and contacted that provider, asked how they went about it. They shared their success and their ability to partner with us for that process, and really that drove other folks to be interested also. The essential component for success really, though, is the community-wide approach that we took. We involved all provider settings. It wasn't a siloed hospital application. We made sure that all of the settings were involved, including physician practices and the hospitalists in the root cause analysis, and also the community service providers that were within those communities. A lot of what we did was break down the silos, because with some of these providers, these were large communities. They had not worked together on any programs in the past. So our charge was really to help them communicate and build partnerships, help them understand each other's settings, and really help them build consensus on what they saw within their root cause analysis, and also in selecting an intervention or interventions to build into their CCTP application. And that technical assistance was ongoing throughout the whole process, from the start of the decision down to all of their meetings with CMS post-award when they needed to submit some additional information for their application. We did do a community-based root cause analysis, and that was also a success. We had some very easy-to-use tools that all of the providers and the community service providers utilized, and we helped them analyze what they found within that analysis. Intervention selection and implementation was also part of the guidance, as well as helping them adopt a budget and develop a budget. And you can think of all of the intricacies of that when you have 10 hospitals and 10 community-based organizations to come to consensus. We also helped them with reapplication support. So if they were denied the first time by CMS, we were the cheerleaders and told them that they had every opportunity to reapply, help them restructure their application, build in what CMS was looking for when they had their debrief calls, and help them with that reapplication support. And I can say each one of them that we helped with actually did receive funding. Our work also was providing moral support, because it's one thing to write the application, decide on what to do, but when you actually come to the point of implementation, there was a lot of support given they could actually do it. So we're still in touch with these communities, and the wonderful thing is that these folks are the champions and the mentors and resources to other communities and providers, not just in New York State, but also on a national level. They're doing a lot of outreach to some of the other states, and these communities really have grown. So we're very, very proud of their success. Thank you.
Thank you, Sarah. I want, and again, thank you all to all of our first four presenters. I don't know if I can speak for everybody, but I think you did an excellent job of making us, the rest of us, feel inadequate. Like, why we do these things. Next, we're going to move into the next section of our webinar today. We're going to have two longer presentations that are going to focus on identified gaps that are still remaining in efforts to improve care transitions. You're not going to get magic formulas to resolve these issues, but we hope that the presentations will generate a good discussion about what the QIO community and CMS can do to help address them. First, Stefan Gravenstein and Rebecca Gardner from Health-Centric Advisors, which is the Rhode Island QIO, will talk about how Health-Centric Advisors has used quality metrics to identify opportunities for improvement. Lynn Chase, who's the lead for Rhode Island's Safe Transitions Program, also helped prepare this presentation, and she's also on the line with Stefan and Rebecca. Stefan and Rebecca?
Thank you for allowing Dr. Gardner and me the opportunity to speak with you about really this exciting work. Even with all the progress that we've just heard about, it's pretty intimidating when you think about how much is getting done out there and the opportunities that we could have had and may have missed. We must acknowledge that we all continue to face barriers in getting this work done. So in the next 15 minutes, we're going to highlight some of those barriers and discuss approaches to addressing them right now and continuing into the next scope of work. So advance, please. Coming from beautiful Rhode Island, we've been fortunate to be engaged in care transitions work since 2008 as one of the initial pilot programs during the 9th scope of work. When we approached this work, we also thought very carefully about how do we get our community involved. And I'm sure all of you have experienced the initial storming that happens. Not me, I'm not the problem. Are these really avoidable readmissions? When they get there, they're really not avoidable, right? And so on. So you've heard that song and dance. Rebecca and I will now take us through some of those so-on barriers we've had past the initial storming and along the way to get us to measuring and accountability. Rebecca? Advance. Okay.
Rebecca, are you able to hear us?
Sorry, Rebecca. So I'll start for Rebecca until she kicks in. This graph shows readmission rates in Rhode Island from the start of our work. At the start of the 10th scope of work, it included the population expanded from a selected target group of beneficiaries to the whole state. Are you ready? I think Rebecca is still trying to get in, so I'll continue. You'll notice the adorable hissing sea line in the bottom left of the screen. This is to remind us of a progression that had to occur in all the settings when we first started off doing this work. There seemed to be a 1 to 2 year period of storming and norming before people could really get down to business. I'm not knocking this, and it's probably unfair to call it a barrier. It does seem to be an important part of the process when new partners come together for the first time on the issue, but it certainly has factored into the timeline.
Great, thank you, Stefan. The next important thing to think about, if you could, is the elephant in the room. As with back a slide, thanks. As with any endeavor, it's important to acknowledge the elephant, to address it, and then continue to move forward so it doesn't become a barrier. And for care transitions work, particularly when it's been labeled a readmissions reduction program, the elephant in the room back in 2008 was that the hospitals had a lot to lose in the beginning of our efforts. And we sought to overcome this barrier more by framing our work as a safe transitions project, which emphasized the patient safety aspect of doing transitions well. And this actually was truly a more accurate reflection of the breadth of activities in that 9th scope of work pilot. So we're now finding that hospital resistance is much less of a barrier given the penalties and incentives that are currently in place from CMS and others. However, we've seen the legacy of this barrier and challenges that continue, so now the pendulum often swings the other way. And if the QA effort in a hospital is not directly linked to readmission reductions, there can be some less interest or focus on it from the hospitals. But in order to overcome this, we again bring it back to the same themes, the patient experience, patient safety, and we emphasize that this is what colleagues in the community feel is needed to safely care for the patients that we all share. Advance. Thanks. So keeping the animal theme going, just one more slide if you can bear with us here. This is a carpfish, which in traditional Chinese culture symbolizes perseverance in overcoming life's barriers. And this is appropriate as we continue to discuss the ongoing challenges with improving care transitions. A key ongoing barrier that we'll discuss in more detail in a few minutes is obtaining physician engagement and buy-in. When working with anyone, physician, non-physician, it's really nice to be able to present data, but this still is especially important when engaging with and working with physicians. And we found that a lack of good quality clinical trials that test interventions that we recommend presented a real challenge. I'm going to defer any further comment on this to the folks who are giving the next presentation. And I'll mention a few other ongoing challenges, some of which we've been able to address, and we'll tell you more about that, and others which we continue to face. These barriers include things like who has the accountability for the transition, both within a setting and across settings. Another barrier is the varying ability of patients to participate in their care and to self-manage. This may be due to health literacy, cognitive impairment, competing psychosocial stressors, and at the same time, we inconsistently include caregivers in the process. We've also noted limited availability of palliative care resources, particularly after patients leave the hospital, and then inconsistent communication about the care choices that patients have after they leave across settings. Another important barrier is that we felt it was really important to include all patients in a setting or facility regardless of the payer. In other words, those non-Medicare fee-for-service patients as well. And this felt important in order to make the intervention feel more fully integrated and robust in a particular setting. And the last barrier I wanted to mention at this point was getting providers and communities to track their implementation and the effectiveness of their interventions. And this may be due to a number of reasons. Perhaps the burden of data collection itself. Perhaps it's because they don't align, the things we're asking them to collect don't align with other data or measurement needs. And in some settings, they just didn't seem to have any experience in systematic data collection, particularly out of the hospital setting. And they don't necessarily feel why it may be important to do this, particularly when the intervention itself seems to have high faith validity. Next slide. So one way of addressing many of these barriers was by asking for and expecting reciprocal change from the settings we were working with. And most of the care transitions issues by definition cross multiple settings. And when we ask one setting to change, such as a hospital, we want to make sure that they're getting what they need from their partners in the community to take care of the patients they share. We also want to make sure that the activities that they take on are truly wanted and used by the sending and receiving providers. And this obviously requires an integrated and holistic strategy, which in Rhode Island turned into a set of best practices to improve care transitions. And the 6 settings that you can see here on this slide, the hospital, the skilled nursing facility, long-term care, home health, et cetera, these 6 settings are the ones for which we develop specific best practices. These best practices are specific to the setting and address what's in the control of that particular setting, but they also encompass what's needed from other providers to share patients with that setting. And at a minimum, they establish core expectations for what should be done in that setting to promote care transitions. I'm going to briefly describe the multi-step process to develop these. We started with reviewing the evidence base where it exists, medical literature, materials from national quality improvement campaigns, and then simultaneously gathered feedback about what folks in the community, what their preferences were, from a convenient sample of physicians and nurses working in both the settings that we were honing in on, as well as the settings that referred patients to that setting or receive patients from them, such as primary care doctors. And then using both of these types of information, we drafted our initial set of best practices and then conducted a series of community meetings to elicit more formal feedback on the concepts as well as the feasibility of it. After these meetings, we revised the best practices substantially and then finally vetted them with our own project leadership advisory board, which also has a wide array of healthcare stakeholders. Next slide. So what is the best practice? It depends on the setting, but there are some common themes, and you can see those here. They involve transferring information across the settings, effective patient education, which hopefully can lead to activation, management of medications, ensuring that recommended follow-up care is in place for the patient, and then being responsive to other clinicians when they reach out for information about the patients that you've seen. So I'm going to give a couple examples in a couple of different settings just to give you a more specific idea. And you can see that they range from very basic things that you would kind of hope are going on already to somewhat more avant-garde, shall we say. So for the hospital setting, one of the best practices is notifying primary care providers about the fact that the patient's in the hospital. Seems pretty basic, doesn't always happen. Another one might be providing the patient with a follow-up phone number at the time of discharge. The patient has somewhere to call with questions about the hospital stay. And this last one is inviting the primary care provider to participate in hospital end-of-life discussions. So this is a great example of a best practice that probably is not in itself going to lower readmissions, but it does speak directly to what is best for the patient and to what community physicians feel they want and need to best care for patients after discharge. It's aspirational, but that's okay. And those are just 3 examples of what I believe are 9 best practices for the hospital setting. For the nursing home setting, there's 11. 2 of them include scheduling outpatient follow-up appointments for patients who are leaving the SNF section of the facility, and things like facilitating residents' access to medications after discharge. In other words, making sure that patients have enough medications to last them to their first outpatient follow-up appointment. Next slide. So we found that these best practices address many of the barriers that we've talked about so far. The bulldozer may actually not be the best image for this because it's not necessarily representative of a collaborative process, which implementing the best practices certainly is. But there in the shovel, you can see what one of the measure specification documents looks like. It includes the things you would expect in order to that you might need to implement the measure. And these are things like the numerator, denominator, exclusion criteria, more detailed definitions, and potential data sources. We have found that the best practices reduce barriers for several reasons, and a few of these are that they establish those minimal expectations across the settings that help assign accountability, both within the setting and across settings. They can also help you get wider endorsement for the work overall, because we often have noticed that facilities will start these as pilots, which allows for easier measurement of outcomes. And then you have in your hand local data that you can use to obtain buy-in, and then scale the intervention either within a particular setting, or you can more easily expand it to a different but related setting. Another reason that they address some of these barriers is that they involve both patients and informal caregivers explicitly, and they include an assessment of the patient and caregiver's level of understanding, which helps the facility identify who the key learner really is. Lastly, and I think perhaps most importantly, they really provide a framework for measurement, which we feel is particularly helpful for settings that are not as experienced with systematic data collection. In addition to the measurement specifications, we have provided data collection tools and an implementation guide, and these suggest process and tracking measures, and this is along with the on-site technical assistance that all the QIs do so well. So that's an overview of the challenges and barriers that we've encountered when working on care transitions, both during the night and temp scopes of work, as well as how our creation and implementation of the best practices has helped us to overcome many of them. And Stefan can now bring us up to kind of where we are now with this work.
Thank you. So we continue to work on implementation and measurement with all of our providers and settings. And you know, if you saw the Blue Cross Blue Shield logo in the front, that's where I'll start. one of the strategies has been to not just have our providers in the room, but also our insurers. And so we've worked with our insurers to incorporate contracting specifically with the best practices as we've coined them with our community providers. They've been in the room, they've agreed with it, and they've also agreed with us on how to measure things. The physician office best practices have been incorporated into the patient-centered medical home contracts with our community outpatient providers. Integration into contracts has helped us to overcome barriers like having to limit the interventions to patients with certain payers, having to make the case for prioritization of this work, and ultimately sustainability. We recognized early on that if we just, for example, worked on heart failure or heart attacks or something like this, that our providers would be picking specifically interventions that might work with a group and then not recognize that it was in fact exactly the same work for all the other patients too, and it should become part of the culture of care. So by generating a contracting approach and making this for all patients, it also becomes a culture of care. And I think that's one of the reasons that in Rhode Island we've seen dramatic improvement across the state, not just in the ones that we have the closest contact with. We continue to work on sustainability in each individual setting as well as spread for these best practices throughout the state. Another way we approach dissemination is by presenting our work at regional and national meetings, and presenting that work has actually been a strategy that has helped us get buy-in from our academic partners. They always want to see data, and they want to see data that's beyond just themselves, but what's the evidence that what we're doing makes a difference, and what's our comparison group, and so forth. By having the data and by getting folks to measure it, we in fact get much closer to that. And ultimately, this translates into publications. Next slide. So as we look toward the next segment of work, we know it won't be a smooth road, kind of like the detour sign. So not just the barriers that we've talked about today, but there's shifting penalties and other shifting landscape that we have to worry about as we go, and we have to incorporate those into the work and the recommendations we make. Across the QIOs, we've all laid the groundwork during the 10th scope of work. We don't have a crystal ball, but we do believe that as QIOs, our care transitions work is preparing us for the changing healthcare world, which will be certainly grounded in collaboration, population-based disease management, and patient-centered health. So in our own state, and I'm sure this is true in yours, many of the barriers in care transition stem from local issues, and they will all look a little different depending on where you're standing. With our community coalitions and with our ongoing relationships with a wide range of healthcare stakeholders, we are well positioned to be attuned to those new barriers as they arise and have the expertise, experience, and relationships to take them on successfully. They now reach out to us in ways they didn't previously, and I think this is evidence about our success. So the next presentation is about we still have barriers. Just having measures isn't enough. We have to translate our measures into action. It's like having a great form doesn't, in fact, guarantee that the form's completed. Next slide. Here is our contact information. Our stellar AIM lead is listed as well, Lynn Chase. Thank you for listening. We'll be available after the next presentation to take your questions and continue this discussion. This would be the place to connect if you wanted to access our implementation guides and other materials that helped us along the path from our talk to measurement and outcomes and working with our partners. Thank you very much.
Thank you, Stefan, and thank you, Rebecca. Our final speaker is Sharon Eloranta from Qualis Health, which is the Washington State QIO. And I have to say, Sharon, I don't know if you remember this, but I first met Sharon at the beginning of the 9th scope of work at the QualityNet meeting, and she told me how Washington had applied to work with a community that already had very low readmission rates, and they got approved as one of the 14 QIOs to do the work. And then they had to worry about, okay, how are we going to make the readmission rate go down in an area where it already was low? And, of course, they did. And, in fact, Washington State as a whole has low readmission rates, and the QIO has been effective in continuing to decrease readmission rates on a statewide basis in the 10th scope of work. Sharon's going to talk about a barrier that all of us face, one of the elephants in the room, to use the analogy that Stefan and Rebecca did, which is how to engage physicians practicing in the community in care transitions efforts. Sharon?
Thanks, Andy. And yeah, I remember that meeting. And as the Rhode Island team was speaking, I was writing down some notes to myself. And low rates is still an elephant in the room for us in Washington State, but particularly also in Idaho, where we are also the QIO. And they were the second lowest readmission rate in the country. And it provides its own unique challenges. But I'm going to talk about engaging physicians. Next slide, please. That's just a little bit about Qualys Health, I'm sure you know. So let's go to the next slide. Our next slide just reviews very briefly, and I'm sure you'll be relieved to know I thought I was only talking for 5 minutes, so it may not be super long. Some of the more kind of promising tries that Qualys Health has made during this last few months in care transitions with the physicians. So with one of our hospital engagement networks, we have been collaborating to test some interventions directly with primary care providers. I would say physicians' offices have been one of the hardest groups to reach and to motivate. I think the information that the Rhode Island team shared about kind of the aligned incentives and the payment structures and that sort of thing absolutely plays true, and it is true, I think, more even for physician offices than for any of these other settings. They really feel like, why do I care about readmissions? Isn't that a hospital problem? I'm already, taking all these Medicare cuts, all of these things. But collaborating with the HEN has been something that we've been able to do. I think, as other folks have talked about, the hospitalists seem to be the most accessible physician groups because they are so closely aligned with the hospital processes themselves, and in many cases have incentives built into their contracts that revolve around readmissions, so that's been helpful, but again, it's an incomplete picture. I would say one thing that I've discovered recently, and I'll talk about a bit more in a moment, is partnering with AMDA, so the American Medical Directors Association, that represents the medical directors that feel most highly attached or aligned with the professionalism of being a medical director in a skilled nursing facility. Exploring the role of that medical director, it is widely variable across the country, and because skilled nursing facilities are so significant in terms of partnership and the number of Medicare beneficiaries who encounter a skilled nursing facility sometime during their healthcare journey as Medicare beneficiaries, that's really an interesting place to go, and I think there's promising implications for that. We're partnering with our medical association in our state. We just did a webinar last week on the new transitions of care, the TCM codes, that got pretty good responses from our audience. I think one of the continuing problems is that physicians don't show up to these sorts of things. We had 200 people on the line, and maybe a quarter of them were actually physician offices. So the partnering is a good thing. Getting the physicians on the line is another challenge. And I would say Qualys Health has quite extensive book of business on person-centered medical home. For the past 5 years, we've been co-facilitating with the Group Health Research Institute the 5-state or 5-region safety net medical home initiative for the Commonwealth Fund, as well as multiple other PCMH efforts. And I think having expertise, pretty deep expertise in PCMH, does help open some doors with primary care providers. As Rhode Island was talking about, kind of what's known to be best practice for that specific setting, I think the PCMH concepts certainly show the physician offices what their role could look like. Next slide, please. Oh, well, my barrier slide has disappeared. Well, I'm going to actually talk from the little deck that I had, so you're not seeing my future directions slide, but I'm going to tell you what they are, and it's just a bunch of text, so don't worry about that, and I will send it to Adrian after. I think in terms of dealing with physician offices, one of the major things the QIOs need is Part D data. Imagine when you go out to speak to hospitals, nursing homes, home health agencies, you wouldn't go into those meetings without a data report telling the hospital, this is what the readmission rate looks like for the Medicare beneficiaries that have been hospitalized with you. This is what it looks like skilled nursing facility for those folks that come directly out of the hospital to you in the 30 days after, who's going back to the hospital, who's using the emergency room, and so forth. If we're going to continue to try to engage physicians in the community-based types of efforts that we're currently doing that have been portrayed as such good successes in the recently released JAMA article that talked about the 14 pilot programs, I think we absolutely have to have more data about the behavior of the outpatient sector. And I know the data problems are massive. That is the biggest pile of data that CMS has, but it is a distinctly missing piece, and I believe it's a barrier to our being able to really engage physicians, since we don't really know kind of what to tell them about the behavior of their own patients, unless we have data potentially from another payer that we could use. So that's a big one. I would say we need support from CMS, maybe through the contracts or however it needs to be articulated, for belonging to and attaining podium opportunities for physician-based organizations and meetings. I was lucky enough to be able to attend the AMDA meeting this last late winter, early spring. I think I was one of the only people representing the QIO program there, and the medical directors in the long-term care setting appear not to be brought into the loop very well by the administrators and directors of nursing that are usually the participants in our activities with nursing homes on care transitions or even in the Quality Care Collaborative. And when you think about the importance of the medical directors in the nursing homes in terms of overseeing the overall quality improvement activities for the facilities and their affiliated prescribers, doing the prescribing, doing those care plans, managing the polypharmacy, all of those issues, to have that group completely sidelined and not even aware of the activities of the QIOs is a big problem. So I would implore CMS to do some thinking about how we could have relationships with associations such as AMDA, even American Medical Association, maybe some specialty societies such as Society for Hospital Medicine, to make those physician-to-physician contacts that would help open some of those doors for us to be more effective in working with physicians. And the last thing I'm going to talk about in terms of a future direction for care transitions and working with physicians is if there could be some incentives, either through ACOs or bundled payments or innovation contracts or something else that would make it more attractive for physician offices, physician clinics to do quality improvement skill building at their practice level. I think most hospitals have some sort of QI skills. Some are extremely sophisticated. They have Six Sigma black belts and all sorts of expertise. Some are heavily into lean and so forth. But in physician offices, this is an area where I think skill building would really play a big part. If you're asking them to transform their practice, to take on person-centered medical home, to really be a good receiver for the patients that are coming out of the skilled nursing facilities, coming out of home health, coming out of hospitals, and keeping their patients, at home as much as possible as is appropriate, then they'll need some type of ability to manage a QI program on that level. And I think who better to assist some of these folks that may need the help than the quality improvement organizations that have so ably assisted other settings. So those are the few future directions I thought of. And again, I will make sure that Dr. Mims has this particular slide that I'm looking at.
Thank you very much, Sharon. And now what we're going to do is ask those of you who've joined the webinar to participate in a discussion. It may be more efficient to do that where you submit comments or questions via the chat. If you're only connected on the phone, or if you feel like that you really need to say something rather than typing it in, you can use unmute your phone by doing *6*. And then if you do that, please remute your phone by *6* again after you're done. Here we have the slide. So we're going to open it up. well, unless somebody has something right away to start us off, I wanted to go back to Sharon and just, in terms of engaging physicians, is it in the community, is it that they don't understand or buy into their role as in care transitions, or is it time and resource, financial pressures that keep them from being involved as much as we might like them to be?
Well, I would say it's both, but I think the other big elephant in the room, it's not an elephant, it's more like that cat picture they showed, which is that where are the physicians? It is kind of like herding cats. You can know that you have, 90 hospitals and you know where they are. You can know you have 225 nursing homes, 65 home health agencies, but you have thousands of physicians, and some of them work in, single provider practices. The ones that are easiest for us to find, I think, across the country are the ones that are directly affiliated with a healthcare system or hospital. And you can go out and at least know where they are and can maybe get a contact that could help engage those. But the vast majority of primary care and relevant specialty care physicians in the country still are not affiliated directly with the system. That may change over the next 5 years or so. But just finding them.
Right. Okay. Thank you. And Adrian or Jen, have you seen anything on the chat that I'm not seeing where people have questions or issues?
One question, and this is from the success stories, if they can answer this question. How is your effort for trying to improve readmissions different in urban versus rural communities?
So this is for Barb or Karen or Hillary or Sarah, and we know you all have both urban and rural communities in your states.
And you have to press *6* to unmute your line.
This is Barb. I think in some of our rural areas, access to care, physical access to care is a real challenge, that they don't have a public transportation system. We do in a urban situation. Some of them don't have electricity, they don't have phones, which we have also in the urban area. But, the strategies are sometimes a little bit different. I know, just as an example, we have a Native American area that has actually no electricity. They barely have running water. And what one hospital did is they created backpacks for their CHS population that includes cell phones, a scale, blood pressure monitor, and they're to call in every day to their CHS coach with their cell phone. Well, the problem is, how do you charge that cell phone? So what they did is they found solar panels that they can take to put out in the sun. They're out on Native American land. They have plenty of sun. And they charged it that way every day, and they put all of these supplies within the backpack. And so because they had such a larger population that they are dealing with this, they came up with a solution that we can now import, perhaps, into the urban area with some of our homeless population in the urban area. So that's just one example that I can think of.
This is Karen from North Carolina. One of the biggest challenges, I think, for the rural communities is the fact that when you're looking to your community, your area on aging, to be good participants and be able to support the efforts, we found that the greatest challenge was that they didn't have the funding. Their population, the funding, how they receive it was based on the population they served and the wealth of the county. Well, interesting enough, in North Carolina, it's a really nice place to retire. And so a lot of people have a lot of homes, but they may not be there. And so it kind of artificially inflates the wealth of the county. So the area on aging has very limited funding. So we had to be very creative because we didn't have a lot of options many times in the hospitals. Again, like Barb said, many of them, some of them we've had were critical access hospitals were struggling for their bottom line. So they didn't have money to start up community interventions. So we have seeing some very out-of-the-box type of things. One of them is realizing our EMS. And our EMS in many of our rural communities started a program where they actually are going in and checking in and doing care transition check-ins with the referrals out of the hospital. So that's just one example of how we've had to overcome some issues here with our rural communities.
And this is Sarah in New York. From a partnership strategy, which we found the community-wide approach to be most successful, the rural communities tend to be mostly close-knit for the providers because they're used to working together to address some of the care management needs of the patients within their community. And not so much within the urban regions. So there were, as far as partnering folks together, different issues or different strategies we had to utilize for the urban areas. But interestingly, the drivers of the readmissions were pretty much the same within both rural and urban regions related to communication, information sharing, and really following the patient across the continuum. But the interventions and how they were addressed, just as was mentioned before, the transportation issues. I mean, we had one community that had no pharmacy. There was one commercial pharmacy within the community that wasn't open certain hours during the weekend. So that was a difficult challenge that they had to address in developing interventions. But the drivers of the readmissions and the issues that they were experiencing were pretty much the same between each of those two areas.
Hi, Andy and company. This is Sharon, and I know I didn't give a speech about this, so I hope you don't mind if I throw in just another thing about rural areas.
Go ahead.
Is that although, well, I've read some studies that seem to indicate that the complicating factors of mental health issues can be more acutely felt in rural areas than in others. I'm not sure if that's necessarily the case everywhere, but for those cases in which, mental health and behavioral health problems are impacting the readmissions, the shortage of behavioral health providers in rural areas is a real problem. But kind of the happy stuff about that is that there are some really interesting models. There's one called MHIP, or Mental Health Integration Program, which uses a behavioral health liaison in the primary care office that has a liaison to a psychiatrist at a university. That has been shown to work in Minnesota and in Washington State. So that kind of mental health issue is there. And I think as we see integration of the adult state population under health care reform in those states that are going to do that, we can't, as Mariah was saying, you can't ignore the other payers issues as well, and that's going to be a big one for us.
It's Stephen Grandson from Rhode Island. There was a request for those of you that aren't on the web about our tracking tools and our best practices. You can access those directly on the ICTC website, or you can email Lchase, L-C-H-A-S-E, at healthcentricadvisors.org, and she can give you all of those materials, including implementation guides and so forth. So please do that. There was another question on the web thing that said, so what's next? What's the next big thing? And I thought I would just give a second to comment on this. Our sense is that one of the things that we systematically don't do very well right now is to educate our patients adequately. We have a different solution for each patient. And one of the things that we learned by implementing the Coleman model was essentially that there is a way to teach patients successfully and know that they've learned. We are calling that right back, and by filling out a PHR, you get to that. It's something that you escape from with the electronic health portal approach, because typically in the electronic health portals, the information is produced there by the provider, and it doesn't really require patient engagement or patient understanding, and there's no evidence that the patient understands or has learned what they read there. So we think that that's one of the reasons the Coleman four-pillar approach has been effective in the real world. So how to do that, how to make that happen, I think is one of the under-studied, not well understood pieces that we have a place for great games.
Hi, this is Rebecca Gardner, also from Rhode Island. To build on what Stefan was saying, something that we've learned a lot during this scope of work was identifying who the key learner is in the interaction, and that gets to Stefan's point about how do we teach people, how do we know that they've learned, doing that key teach back and assessing the knowledge. And so we are starting to be more actively seeking out who those key learners are, reminding our providers that we work with that they need to figure out if it's the patient and the caregiver, or the caregiver, or maybe someone else altogether who's going to be engaging and helping with self-management for the patient.
This is Barb in Arizona. I'll just kind of follow up with that, too, that one of the things that we've really identified is that sometimes it's just the small things that we overlook when it comes to patient education. We had a session where we had every provider in the continuum bring their education on CHF. And everybody had some different materials. They did not have a common language. So when you talk to a patient about, if you have a weight gain of 2 pounds in 4 days, or 3 pounds in 7 days, or some of them said when your clothes get tight. And so you figure if a patient is in the hospital, then in the nursing home, and then in the home with home health, they're getting 3 different sets of patient education material about the same topic, and yet none of them are coordinated or standardized, and we are not using common language. So in this one particular community with about 8 hospitals and 12 nursing homes and home health agencies, they took materials and they developed common language that they imported into their own unique materials, because patients get overwhelmed and then they give up. And so that's one of the things that I think that could be done is standardization in some of the simple things. Another thing that I think in the next scope that I'm hoping that would be a next big opportunity is really having some very candid conversation between hospitals and nursing homes and home health agencies about what are the causations of the readmissions. And we have one community here that meets every month, 3 hospitals and their 10 nursing homes in their geographic community, and they all use the Advancing Excellence readmission tracking tool. And one by one, every nursing home gets in front of each other, which are their competitors, with a flash drive, and they share up on the screen their data on readmissions, and they go into the causations of what's occurring. And there have been amazing changes in that community, most of which have been on the hospital side, actually, as opposed to the nursing home. So the nursing homes are sharing the information, but the hospitals are finding that the contributing causes are the root are in the transfer and the handoff from the hospital to the nursing home. It just trickles down through the continuum. So I think that would be a great opportunity that I would love to see in the next scope, is having more focus in that way.
This is Karen from North Carolina, and just our thoughts for the next scope of work that we've seen out of all of the communities across North Carolina is that the emergency department is a revolving door and can be a great portal, if you will, to be the gatekeeper to not prevent a lot of these avoidable readmissions happening. When we've done the work, we're noticing the continued trend through the scorecards that we're getting quarterly on the increasing number of our emergency department utilization going up and up and up. So our readmissions are going down, but that EDs are going up. And we have a physician consultant that's working with us and who is an active ED physician. He's done a lot of work in this, and we're actually getting ready to we're going to be doing a 4-part series on the role of the emergency department in care transition coming out of the Carolinas. And what's really concerning is the fact that this is really low-hanging fruit, because a lot of times the individual, the patient, caregivers, they get out of the hospital and they're overwhelmed, and if they can't get in touch with their physician or get to see their doctor or don't have a doctor, they're going to go back to the emergency department. And the emergency departments are overwhelmed with the volumes, and so a lot of times they'll admit them just to finish up what needs to be done. And so really this is a great opportunity. We've been doing a lot of work amongst our communities to really look at the case management program, to actually look at having specialized areas in the emergency department that has that ability to connect with the social services, to be able to get those PIC lines in, to be able to do what needs to be done to get them back home and avoid another readmission. So I think the role of the ED in care transitions is something that we're hoping, gets some attention in the 11th scope.
Thanks, Karen. This is Andy. One thing we haven't really discussed today is palliative care. I mean, there are the patients who are going to be readmitted even if the system is working perfectly and they're getting all the supports they need because their chronic conditions are advancing and they're just going to become acutely ill. And palliative care and hospice are options to that. Does anybody have any suggestions or successes to share in that area?
Andy, this is Barb. I just don't really have a strong success story. I just really want to echo that sentiment. We have found that in Arizona, when the hospitals did their root cause analysis for readmissions, the lack of referral to palliative and hospice care was usually in the top 3 reasons for readmission. And we developed on our website a toolkit for palliative care in order to assist hospitals to develop that program. But I think, and even those that are referred to hospice are generally referred to hospice, I think the average in Arizona is about 10 days before they have. So we see this as a common issue as well, and I think it's an area that we really need to strongly focus on. So I just kind of want to echo your sentiment in that regard.
And thank you. And I should add that, and you're talking about hospitals recognizing there's a problem. Once patients are out of the hospital in the post-acute care system, there's even more problem, I think.
Andy, this is Sarah. One of the things we've found in working with both palliative care and hospice for care transitions in 10 scope of work is really the lack of all of the healthcare providers' comfort level in being able to talk with the patients and their families about both of those options. And one of the things we focused on in this scope of work, working with our statewide MULST coordinator, is education for the different provider settings, including physicians, on developing talking strategies and how to talk to families about those options. Because we don't see them being offered, and there's really not that comfort level we're finding in being able to have that conversation with the patient. And we're seeing some progress with providers now being able, we had some sessions with role playing. We did a video that's on YouTube along with the statewide MULST coordinator on how to have the conversation. But that's one area I think definitely we could focus on in the 11th scope of work.
Yeah, thank you. That really is an opportunity where to provide that training and support to physicians so they are comfortable doing this. Adrian and Jen, I don't want to cut off conversation or discussion. Are we okay to continue on, or do we need to wrap up?
We have about 5 more minutes.
Okay, good. Anybody else want to, add anything? Adrian, I saw there's a question about, as things get designed for the future, has anybody have any suggestions on how do we measure progress in the area or success in the areas that we're working?
Hi, it's Stephen Granson from Rhode Island. In one hospital, we've now started a new measurement of whether patients have learned things. And essentially what we did was we took the 4 pillars and said, what is it that we want them to learn? And we ask them now, when they come in, do they know their diagnoses? Do they know their medications? Do they know any of their symptoms or warning signs? And we ask that serially through the hospital stay, with the hope that the number of no's we get gets reduced as a percentage of those 4 items.
And is that being measured by the hospital in the hospital where that's being used, or?
We have just started it, so yes, we are measuring it.
Right. Okay, that's great. So you're taking a more active role as opposed to, all right, we provide education and teaching for the patient, and we do teach back. You're saying we don't need to wait till we're doing the education. We can be checking in on the patient's knowledge.
Right. So this is essentially a process question. Is anybody teaching it?
Right.
And if the processes are working, we should be getting to more yeses by the time we leave.
Absolutely. Or is anybody teaching it effectively, I guess, is the other part of that.
Andy, this is Sarah. More on the redesign piece, I think another opportunity really would be to incorporate on a stronger level integrating the community service providers that are out in the community to assist the hospitals, home health, physicians, nursing homes. They can only do so much, and what we found in some of our focus groups is that there are those services out in the community, but those providers really aren't aware of what those services are, whether they be county-based or state-based or even just volunteer-based within the community, such as transportation. So I think connecting the healthcare providers with those community service providers would really have a big impact on the care management and reducing readmissions.
Thank you for that, Sarah. That's something that when we think about Medicare providers, these are not who you're talking about are not Medicare providers, but they clearly play a really important role in the coordination of care for patients with chronic conditions.
Absolutely.
So Andy, thank you very much, and thank you to all of the presenters who have been on the line with us today. Everybody who has joined the webinar will receive a evaluation form over the next couple of days, and once you complete that, we will send you a certificate of completion. Those of you who are on the phone but not on the webinar who are interested in receiving the slides, you can send me an email and we'll make sure that you get that information. I think this has been an excellent webinar today, and just to let you know that we are continuing the series, and although many on the line may have been about reducing readmissions, when we come to talking about medication safety next week and heart health, value-based purchasing, patient and family engagement, and end-of-life palliative care, those all impact readmissions, and so you're very much invited to be part of those conversations too. So thank you very much, Andy, and all presenters.
And thank you, Adrienne, also.
Okay, goodbye.